The title of my article is Acetic Acid Iontophoresis for Recalcitrant Scarring in Postoperative Hand Patients. The authors are Dardis, Bay, Yule, Wright, Strawn, and Day, and it was published in the Journal of Hand Therapy in 2014. The purpose of the study is to investigate how acetic acid iontophoresis affects hand function for patients with recalcitrant scarring secondary to open trigger finger release. The design is a retrospective cohort comparison. The level of evidence is a level 3 due to being non-randomized and including a small sample size. The sample size is 17 participants, however, because there was multiple digits involved with some participants, the authors will be referring to the groups as including 23 digits. The hypothesis is, will acetic acid iontophoresis improve hand function in individuals with open trigger finger release with recalcitrant scarring whose improvements plateaued from standard occupational therapy? The inclusion criteria was adult patients with open trigger finger release with recalcitrant scarring who were followed at a specific outpatient hand facility whose name was not given. The exclusion criteria are patients who have not had an open trigger finger release with recalcitrant scarring, patients not followed at the specific hand facility, children, patients who were pregnant, patients who had an intolerance to iontophoresis, and anyone who had a history of cancer in the previous 5 years. The intervention for Group 1 included patients who showed optimal recovery following standard care at the hand therapy facility according to increase in total range of motion. These participants received standard of care occupational therapy for 14 sessions after wounds were healed. Standard of care was typically 12 days post-surgery. The standard of care included treatment to increase range of motion, tendon glides, edema control, dressing changes, extension orthotic use at night, use of hot packs, and stretching exercises. The intervention for Group 2 included participants whose recovery plateaued after the 14 standard of care sessions as presented by range of motion scores. A plateau and range of motion score was defined as no improvement in total range of motion in 2 consecutive treatment sessions. After 14 days receiving standard care, participants received an additional 7 days of acetic acid iontophoresis, which was performed 2 times a week for an average of 4 weeks. The dosage began at 40 milliamp minutes and increased to 50 milliamp minutes if there was no adverse reaction. The current was between 2.5 to 4 milliamps. The outcomes found was a comparison of age for Group 1 and 2. Group 1 averaged 65 years old, and Group 2 averaged around 58 years old, so Group 1 had older participants. The researchers set statistical significance at p less than 0.05. Prior to intervention, Group 2 rated pain higher than Group 1 via the visual analog scale, p less than 0.05. And the researchers added together the scores for each joint of involved digits for Group 1 and 2, and the joints include MP, PIP, and DIP. Participants in Group 1 responded well to standard care. Their total range of motion pre-standard hand therapy was 183, and the total range of motion post-hand therapy was 245. Participants in Group 2 who had a plateau after receiving standard care, their range of motion was 186 prior to hand therapy, and post-standard hand therapy was 219. And then after receiving acetic acid iontophoresis for 7 days, their range of motion increased to 239.4. The strengths of the study is that it contributed to evidence on the use of acetic acid iontophoresis for the population of people who experience recalcitrant scarring following injury and/or surgery. And the limitation is that the study used a small sample size of 17 participants, or 23 fingers. The participants were not chosen randomly, which leaves possibility for bias. There was a lack of power analysis performed. Authors did not specify who analyzed the data, which is also another risk for bias. The authors point out that there was variation among delivery schedule of the acetic acid iontophoresis and in which stage of recovery the participants were when they were receiving the medication. There was also a lack of description or data pertaining to the scar pre- and post-treatment. Implications for practice. Outcomes for both Group 1 and Group 2 demonstrate improved range of motion from standard occupational therapy for clients who had open trigger finger release with recalcitrant scarring. The study provides evidence to further support occupational therapy combined with modalities such as iontophoresis when clients are not showing continued improvements. It specifically supports acetic acid iontophoresis as a modality to treat recalcitrant scarring by remodeling collagen, ultimately affecting the range of motion and allowing clients to maintain function, independence, and to help reach personal goals. The pain levels were significantly higher for participants in Group 2 who did not recover as well from standard hand therapy care alone, and this is emphasizing that pain levels can interfere with participation in therapy and could have played a role in the decreased recovery, and this is important to remember to keep in mind assessing pain prior to treatment. Also being mindful to treat clients during times where pain levels are at their lowest and providing modalities to decrease pain relief if necessary. Thank you.